Welcome to the Pharmacologic Glycemic Management of Type 2 Diabetes chapter of the 2018 Diabetes Canada Clinical Practice Guidelines. My name is Dr. Robin Holden. I'm Professor and Chair of the Division of Endocrinology at Queen's University and had the pleasure of serving as Chair of the 2018 Guidelines. This version of the chapter used material from previous iterations, and this slide acknowledges authorship for the latest version as well as the 2013 guidelines and 2015 and 2016 updates. I would like to thank lead author Dr. Lorraine Lipscomb and her co-authors for all of their hard work. Key changes in the 2018 chapter include an updated algorithm on the management of hyperglycemia in type 2 diabetes, new information and recommendations on anti-hyperglycemic agents released after 2013, CV outcome studies, as well as an updated figure and appendix on anti-hyperglycemic agents and renal function. This slide shows a checklist illustrating some of the key principles in the pharmacologic glycemic management of type 2 diabetes. These include choose initial therapy based on the degree of glycemia, start with metformin, with or without other anti-hyperglycemic agents, individualized therapy based on characteristics of the person with diabetes and the anti-hyperglycemic agent, and finally make timely adjustments to attain the target A1C within 3 to 6 months of diagnosis. A change from the 2013 guidelines is the next step is based on the patient's individualized A1C target rather than an absolute value. If the A1C is less than 1.5% above the patient's individualized target A1C, initiate healthy behavior interventions and start metformin if not at target in 3 months, or start metformin with healthy behavior interventions. If the A1C is greater than or equal to 1.5% above the patient's individualized target A1C, start metformin with healthy behavior interventions and consider a second concurrent agent. If the patient has symptomatic hyperglycemia and/or metabolic decompensation, insulin should be initiated alone or in combination with metformin. This includes patients with polyuria, polydipsia, weight loss, or volume depletion, or post-treatment of diabetic ketoacidosis or hyperosmolar hyperglycemic state. A key message is to make timely adjustments to attain the patient's individualized target A1C within 3 to 6 months of diagnosis. This is the updated algorithm for glycemic management of type 2 diabetes. At the time of diagnosis, healthy behavior interventions should be initiated. These include nutritional therapy, weight management, and physical activity. There is also an option to start metformin. A change from the 2013 guidelines is the next step is based on the patient's individualized A1C target rather than an absolute value. If the A1C is less than 1.5% above the patient's target A1C, if they are not at glycemic target within 3 months of healthy behavior interventions, metformin should be started or increased. If the A1C is greater than or equal to 1.5% above target A1C, metformin should be initiated immediately. A second concurrent anti-hyperglycemic agent should be considered. If the patient has symptomatic hyperglycemia and/or metabolic decompensation, insulin should be initiated alone or in combination with metformin. This includes patients with dehydration, diabetic ketoacidosis, or hyperosmolar hyperglycemic state. If the patient remains not at glycemic target, the first question to ask in choosing the second anti-hyperglycemic agent is whether the patient has clinical cardiovascular disease. Clinical cardiovascular disease is defined as history of myocardial infarction, coronary artery disease on angiography, unstable angina, stroke, or peripheral artery disease. If the patient has clinical cardiovascular disease, an anti-hyperglycemic agent with demonstrated cardiovascular benefit should be added. This recommendation is based on several cardiovascular safety outcome studies. The EMPA-REG outcome study included 7,020 people with type 2 diabetes and clinical cardiovascular disease. Those treated with empagliflozin had significantly fewer cardiovascular events compared to placebo after 3.1 years of follow-up. This was driven by a significant decrease in cardiovascular mortality, as non-fatal events were not significantly reduced. The LEADER trial enrolled 9,340 participants with type 2 diabetes and high cardiovascular risk. The majority of participants were 50 years of age or older and had at least one cardiovascular condition, including coronary heart disease, cerebrovascular disease, peripheral arterial disease, congestive heart failure, or stage 3 or higher chronic kidney disease. Over a median follow-up of 3.8 years, fewer participants in the liraglutide arm had the primary endpoint of cardiovascular death, non-fatal MI, or non-fatal stroke. While the LEADER trial included some people with cardiovascular risk factors only, over 80% of participants had cardiovascular disease, and only 10.5% of the primary events occurred in those without clinical disease. Therefore, the results are most applicable to people with clinical cardiovascular disease requiring add-on antihyperglycemic therapy. The CANVAS program, which integrated findings from 2 placebo-controlled trials, enrolled 10,142 participants with type 2 diabetes who were 30 years or older with symptomatic cardiovascular disease, or 50 years or older with at least 2 cardiovascular risk factors. Over a median follow-up of 2.4 years, significantly fewer persons randomized to canagliflozin had the primary outcome of cardiovascular death, non-fatal MI, or non-fatal stroke. There were no statistical differences in the individual components of the composite outcome. While 1/3 of participants did not have cardiovascular disease, a significant decrease in the primary endpoint was only found in those with cardiovascular disease. Therefore, as with other cardiovascular outcome trials, these results largely apply to people with type 2 diabetes requiring add-on antihyperglycemic therapy who have established cardiovascular disease. Going back to the glycemic management of type 2 diabetes treatment algorithm, for people with clinical cardiovascular disease not reaching glycemic target, or for people without clinical cardiovascular disease not at target, the choice of the next antihyperglycemic agent is outlined on the next slide. The next antihyperglycemic agent should be selected best suited to the individual based on a variety of clinical considerations. For many patients, avoidance of hypoglycemia and/or weight gain with adequate glycemic efficacy are important considerations. For these patients, an appropriate choice of agent includes a DPP-4 inhibitor, GLP-1 receptor agonist, or SGLT2 inhibitor. For other groups of patients, other considerations may be important. These may include reduced eGFR and/or albuminuria, clinical cardiovascular disease or cardiovascular risk factors, degree of hyperglycemia, other comorbidities such as congestive heart failure or hepatic disease, planning pregnancy, cost, coverage, and patient preference. For patients with chronic kidney disease, an updated appendix called Therapeutic Considerations for Renal Impairment is helpful in selecting the next agent based on the stage of chronic kidney disease. For other groups of patients, the table outlined on the next slide is helpful. This table looks different from the 2013 version. A major change is the placement of the effect on cardiovascular disease outcome column as the first one to emphasize the importance of starting an agent with demonstrated cardiovascular outcome benefit in patients with clinical cardiovascular disease. The agents are not listed in the first column alphabetically, but are listed by cardiovascular outcome data. For drugs with similar cardiovascular outcome data, they are then listed alphabetically. The next column outlines the risk of hypoglycemia with the different classes of antihyperglycemic agents. As you can see, the risk is highest with insulin and insulin secretagogues. The next column outlines the effect on weight. GLP-1 receptor agonists and SGLT2 inhibitors are associated with weight loss. DPP-4 inhibitors are weight neutral. Insulin, TZDs, and insulin secretagogues are associated with weight gain. The next column outlines relative A1C lowering when added to metformin. The greatest reductions are seen with GLP-1 receptor agonists, SGLT2 inhibitors, and insulin. Other therapeutic considerations are listed in this column and include common side effects and dosing information. The last column outlines the relative cost of the different antihyperglycemic agents in relationship to each other. It is important that if glycemic targets are not met, that other anti-hyperglycemic agents from a different class are added and/or an insulin regime is added or intensified. Timely adjustments should be made to attain target A1C levels within 3 to 6 months. Information on use of anti-hyperglycemic medications based on renal function is outlined in this updated figure from the Pharmacologic Glycemic Management of Type 2 Diabetes chapter and is based on product monograph information and clinical trial evidence. Insulin treatment for type 2 diabetes includes human or intermediate-acting basal insulin, long-acting analog basal insulin, both of which may be given once or twice daily for basal glycemic control, human or short-acting bolus insulin, rapid-acting analog bolus insulin, both of which are given at meal times for prandial glycemic control. Premixed insulin is also available, containing mixtures of human basal and bolus insulin or analog basal and bolus insulin. This table outlining the types of insulin has been updated in the 2018 guidelines. It's important to acknowledge that the data represents estimations derived from pooled data analysis using various experimental conditions. The 2018 guidelines contain an appendix entitled Examples of Insulin Initiation and Titration Regimes, which provides useful guidelines on starting and titrating basal insulin, basal plus insulin, basal bolus insulin or multiple daily injection therapy, and premixed insulin. The Targets for Glycemic Control chapter contains a new recommendation that is shown in this appendix entitled Examples of Insulin Initiation and Titration Regimes. Like the 2013 guidelines, the first part states, in order to achieve an A1C less than or equal to 7%, people with diabetes should aim for a fasting or preprandial glucose target of 4 to 7 millimoles per liter and a 2-hour postprandial plasma glucose target of 5 to 10 millimoles per liter. However, a Part B has been added in the 2018 guidelines to reflect evidence from several insulin treat-to-target trials that have safely used dose titration protocols in individuals not at target A1C to reach lower than traditional fasting plasma glucose and postprandial plasma glucose targets. The recommendation states that if an A1C target of less than or equal to 7% cannot be achieved with a fasting plasma glucose target of 4 to 7 millimoles per liter and a postprandial plasma glucose target of 5 to 10 millimoles per liter, further fasting plasma glucose lowering to 4 to 5.5 millimoles per liter and/or postprandial plasma glucose lowering to 5 to 8 millimoles per liter may be considered, but must be balanced against the risk of hypoglycemia. This popular insulin prescription tool has been updated on the Diabetes Canada Guidelines website. In the first step, you choose an insulin type, including basal, prandial or bolus insulin, or premixed insulin. You then choose a brand. In the next step, you select a starting dose and titration instructions for the patient. You then select a pen device, check off the supplies that they'll need, specify the quantity and the repeats, sign and date, and then fax or transmit it to the pharmacy. The reverse side of the document contains more detailed instructions on insulin initiation and titration. The Diabetes Canada Guidelines website contains a helpful tool that provides guidance to healthcare prescribers on selection of anti-hyperglycemic agents. The user is prompted to enter the patient's individualized A1C target and answer questions about the patient's characteristics. A list of appropriate choices of anti-hyperglycemic agents is then generated. Let's now review each of the recommendations contained in this chapter. Recommendation 1 is healthy behavior intervention should be initiated at diagnosis.
Metformin may be used at the time of diagnosis in conjunction with healthy behavior interventions. Recommendation 2 is if glycemic targets are not achieved using healthy behavior interventions alone within 3 months, antihyperglycemic therapy should be added to reduce the risk of microvascular complications. Metformin should be chosen over other agents due to its low risk of hypoglycemia and weight gain and long-term experience. Recommendation 3 is if A1C targets are greater than or equal to 1.5% above target at diagnosis, initiating metformin in combination with a second antihyperglycemic agent should be considered to increase the likelihood of reaching target. Recommendation 4 is individuals with metabolic decompensation, for example, marked hyperglycemia, ketosis, or unintentional weight loss, should receive insulin with or without metformin to correct the relative insulin deficiency. Recommendation 5 is dose adjustments to and/or addition of antihyperglycemic medications should be made in order to attain target A1C within 3 to 6 months. Recommendation 6, if glycemic targets are not achieved with existing antihyperglycemic medications, other classes of agents should be added to improve glycemic control. The choice should be individualized, taking into account the information in the figures and tables contained in the chapter. Recommendation 7, in adults with type 2 diabetes with clinical cardiovascular disease in whom glycemic targets are not achieved with existing antihyperglycemic medications and with an eGFR greater than 30 milliliters per minute, an antihyperglycemic agent with demonstrated cardiovascular outcome benefit should be added to reduce the risk of major cardiovascular events, Grade A Level 1A for empagliflozin, Grade A Level 1A for liraglutide, Grade C Level 2 for canagliflozin, heart failure hospitalization, Grade B Level 2 for empagliflozin, Grade C Level 2 for canagliflozin, and progression of nephropathy, Grade B Level 2 for empagliflozin, Grade C Level 3 for canagliflozin. Recommendation 8, in adults with type 2 diabetes without clinical cardiovascular disease in whom glycemic targets are not achieved with existing antihyperglycemic medications, incretin agents, DPP-4 inhibitors or GLP-1 receptor agonists, and/or SGLT2 inhibitors should be considered as add-on medication over insulin secretagogues, insulin, and TZDs to improve glycemic control if lower risk of hypoglycemia and/or weight gain are priorities. Recommendation 9, for adults with type 2 diabetes with metabolic decompensation, for example, marked hyperglycemia, ketosis, or unintentional weight loss, insulin should be used. Recommendation 10, insulin may be used at any time in the course of type 2 diabetes. In people not achieving glycemic targets on existing non-insulin antihyperglycemic medications, the addition of a once-daily basal insulin regime should be considered over premixed insulins or bolus-only regimes if lower risk of hypoglycemia and/or weight gain are priorities. Recommendation 11, in adults with type 2 diabetes treated with basal insulin therapy if lower risk of hypoglycemia is a priority. Long-acting insulin analogs, insulin glargine U100, glargine U300, detamir, degludec, should be considered over NPH insulin to reduce the risk of nocturnal and symptomatic hypoglycemia. Insulin degludec may be considered over insulin glargine U100 to reduce overall and nocturnal hypoglycemia. And insulin glargine U300 may be considered over insulin glargine U100 to reduce overall and nocturnal hypoglycemia. Recommendation 12, in adults with type 2 diabetes receiving insulin, doses should be adjusted and/or additional antihyperglycemic medications, non-insulin and/or bolus insulin, should be added if glycemic targets are not achieved. A GLP-1 receptor agonist should be considered as add-on therapy before initiating bolus insulin or intensifying insulin to improve glycemic control with weight loss and a lower hypoglycemia risk compared to single or multiple bolus insulin injections. An SGLT2 inhibitor should be considered as add-on therapy to improve glycemic control with weight loss and lower hypoglycemic risk compared to additional insulin. A DPP-4 inhibitor may be considered as add-on therapy to improve glycemic control without weight gain or increased hypoglycemia risk compared to additional insulin. Recommendation 13, when bolus insulin is added to antihyperglycemic agents, Rapid-acting analogs may be used instead of short-acting insulin to improve glycemic control. Recommendation 14, bolus insulin may be initiated using a stepwise approach, starting with one injection at one meal and additional mealtime injections as needed, to achieve similar A1C reduction with lower hypoglycemia risk compared to initiating a full basal bolus insulin regime. Recommendation 15, all individuals with type 2 diabetes currently using or starting therapy with insulin or insulin secretagogues should be counseled about the prevention, recognition, and treatment of hypoglycemia. Recommendation 16, metformin, insulin secretagogues, and SGLT2 inhibitors should be temporarily withheld during acute illnesses associated with reduced oral intake or dehydration. Recommendation 17, SGLT2 inhibitors should be temporarily withheld prior to major surgical procedures and during acute infections and serious illness to reduce the risk of ketoacidosis. The chapter includes a number of key messages for healthcare providers, which I'll show over the next few slides. And it also includes a number of key messages directed for people with diabetes written in lay language, which I'll also show over the next few slides. I encourage you to visit the Diabetes Canada website to review the full text version of this chapter. The same information may also be obtained by downloading the app.